Hello friends. So let's discuss today NEET questions. So till now I could collect just five anesthesia questions. So let's discuss them, and later if you'll find more questions, I'll discuss again. Fortunately, the questions were very easy, and in fact, honestly speaking, if you ask me, nowadays you don't expect such easy questions, but today you comparatively got very easy questions of anesthesia, and fortunately they are almost always or all from our notes also. So if you have even done the basics, you could have done anesthesia questions rightly. So let's start. You're doing lumbar puncture. Last structure to be encountered will be ligamentum flavum, dura, arachnoid, and pia. And this is the screenshot of our notes, which clearly showing the structures which are encountered when you are giving spinal anesthesia. So first to encountered will be skin, then subcutaneous tissue, then is the supraspinous ligament connecting the tip of spinous processes, then interspinous ligament connecting the spinous processes, then ligamentum flavum, then dura, and then arachnoid. So, and this is here you give spinal anesthesia, and that is why you know spinal anesthesia is called as subarachnoid block, because CSF is present between arachnoid and pia. So I don't think anybody would have got this question wrong. So last structure to be encountered will be obviously arachnoid. So very much clear from, you can say clearly from our notes, details we have discussed. Then next question, a patient is undergoing surgery where anesthesia is maintained on halothane. The patient develops severe hyperthermia and muscle rigidity. Which of the following agent would have also contributed to this condition? D-tubocurare, succinylcholine, cisatracurium, rocuronium. Patient developing severe hyperthermia and muscle rigidity, and patient is receiving halothane. There is no second thought that this patient has developed malignant hyperthermia. And the most commonly implicated drug to trigger malignant hyperthermia is succinylcholine, succinylcholine. Succinylcholine. All inhalational agents, they can also trigger malignant hyperthermia, but among inhalational agents, maximally it is seen with halothane. So this was the question. Halothane patient already receiving, then another agent would have, which would have triggered this condition is succinylcholine. So answer should be succinylcholine. And this is the screenshot of our notes clearly showing most commonly implicated drug succinylcholine, and among inhalation agent most commonly implicated inhalation agent is halothane. So again, a very easy question. So I don't also think that anybody could have get this question wrong. And in fact, this is a question you see we discussed directly also during our you can say recording. Clearly we discussed this question. And in fact, so here halothane, and in succinylcholine muscle accent also have discussed the same question exactly. And in fact, I forget to take the screenshot of this question also, where that direct question has also been discussed in our eGurukul app, in our class. Then question number 3. A 30-year-old male was intubated for surgery. The best method to confirm the position of endotracheal tube: X-ray chest, auscultation, capnography, chest expansion. See, there are various methods to confirm the position of your endotracheal tube, like looking at the chest expansion, looking mist in the endotracheal tube, auscultation. But everything can misguide you. Even auscultation can misguide you. Sometimes your tube may be in esophagus and you are hearing the conducted sounds which you can misinterpret as breath sounds. So therefore, surest confirmation of intubation is only and only possible with capnography. See, again, one of the easiest questions related to capnography. In fact, in my class, we discuss the same question. You say, surest confirmation of intubation. So in our recording, the same question has been discussed. But you know, whenever I say, whenever I discuss this question, I always say that those happy days that you are getting such easy questions have gone. But I think happy days have come again. So अच्छे दिन आ गए हैं वापस. Anesthesia के इतने आसान questions आ रहे हैं. So anyway, so surest confirmation is intubation, and this is a screenshot during intubation where we clearly discussed that surest confirmation of intubation is capnography, and during capnography also we discussed the same thing, that surest confirmation of intubation is capnography in the uses of capnography. And question already I told you direct this exactly same question we discussed here, surest confirmation of intubation. Then question number 4. A young male was given regional anesthesia with 0.25% bupivacaine. The patient became unresponsive and pulse became unrecordable. The best management would have been CPCR with 20% intralipid, CPCR with soda bicarb, CPCR with dobutamine, CPCR with calcium. So bupivacaine is highly cardiotoxic, and this cardiac toxicity can manifest in any form, ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia, and ventricular tachyarrhythmias or even ventricular fibrillation leading to cardiac arrest is not quite common, I will say, but yes, not so uncommon after bupivacaine. So this and patient become unresponsive, unrecordable means most probably the drug has gone intravascularly or patient has developed toxicity because of bupivacaine if you have used excessive doses. They didn't mention, even the question they would have mentioned that this incident happened instantly, means intravascular, after some time means toxicity due to overdoses. So this patient has arrested, pulse unrecordable. So obviously you will be starting CPCR, and antidote for bupivacaine is only 20% intralipid. And how intralipid helps? Clearly it binds the active form of bupivacaine. So it binds the active form of bupivacaine. So directly binding the active form, you can say it acts as antidote. So answer should be A. And again, look at the screenshots of eGurukul notes. See, antidote for bupivacaine cardiotoxicity is intralipid. Again, a very direct, very clear question, and again comparatively I will say a easy question. Then one image based question was also there. The image below done for airway management includes head tilt, chin lift, inline Malvern stabilization, jaw thrust, head extension. So this is clearly a part of triple maneuver. So triple maneuver is done to prevent the tongue fall, or you can say opening of the airway, and this requires the parts of triple maneuver is head tilt. Head tilt means neck extension, chin lift, and jaw thrust. Jaw thrust means anterior displacement of the mandible. So obviously this will be done as a basic part. However, in good setups, in hospital setups, if you have airway, you can directly put Goodell's airway. Or if patient is apneic also, you are planning to ventilate, then you can intubate. So endotracheal tube will take care of airway as well as breathing. So here the performer is going to apply this triple maneuver, head tilt. Head tilt means neck extension, I told you. And actually chin lift and head tilt are done as a single maneuver. Here the user has used both hands, but you may not need just chin lift. If you lift the chin, automatically there will be head tilt or extension of head. So even it can be done with one hand only. But here the both hands has been used. So this is head tilt and chin lift. A. Inline manual stabilization means this is done for cervical spine fractures where you are intubating the patients. Like one person will hold head and neck like this to stabilize the neck, and then another person can intubate. Jaw thrust means anterior displacement. It is a part of triple maneuver, but in this diagram, jaw thrust has not been given. And head extension, no, it is actually neck extension. But during intubation, we do extension at atlant-occipital joint and flexion at neck. So don't get confused. So this is to prevent tongue fall, we go for neck extension. But during intubation, we go for neck flexion. So A, and that again we have discussed during our airway management, this triple maneuver, head tilt, that is neck extension, chin lift and jaw thrust. So we already have discussed this thing also in detail during our CPCR section where we have discussed airway management. So this again is a screenshot of our eGurukul notes. So very easy questions in fact. So thank you very much. And again, questions were really very easy. You are lucky enough. And so at least this time anesthesia will get you good marks. Hopefully all of you would have done at least 4. I expect every one of you who had attended classes would have done all questions right, but at least 4 out of 5 without any fail. Anyway, thank you very much, and my best wishes till the results come, and let's wait for the result. Thank you very much again.